Hi everyone. I'm getting ready to start my live today. Hope everyone is having a great day. I just finished clinic right now. I'm looking forward to having Dr. Meivys Garcia on. There she is. Hi everybody. Thanks for joining. Super excited to have Dr. Garcia on. And there she is. Right now, I hope you guys are looking forward to having her on like I am, and it's so fun to see all the people joining us today. Hi, Meivys, how are you?
Very good, thank you. How are you?
I'm doing great. Thank you for being with us today. So why don't you just tell our audience where you're from, a little bit about yourself, just so we can get to know you a little bit better.
Sure. So I work in Toronto, Canada, Markham Fertility Center in Ontario. I've been a fertility specialist for about, 9 years now. And yeah, I have 2 kids, 2 IVF kids
Awesome.
to speak of.
Yeah. So for those of you who watched our or didn't catch our show, we did a show on what to do if your embryo transfer fails or doesn't work.
That's
And
right.
Dr. Garcia has experience with that both personally and obviously professionally. So she brings a very unique approach, both as a patient and as an expert. And she provided a step-by-step guide for us. So if you guys didn't watch that show, please go back and watch it. It's on IGTV and it's also on YouTube as well. And we got so many questions. I just thought I would start asking the questions that were emailed in until we start getting questions that are sent to us during the live chat. So
Sure.
thank
Yeah.
you everyone for joining us. Here we go. So hi, Dr. Amy, and thank you so much for the good work you do. I'm a huge fan. I watched the show that you did with Dr. Garcia and enjoyed it. I had a failed transfer with 2 PGS tested embryos, so I decided to do an ERA test with my upcoming transfer. My question is this: when doing a frozen embryo transfer using a natural cycle, do I need to do the ERA test? Dr. Garcia says she prefers natural cycle transfer as opposed to medicated cycles. So if I want to do a natural cycle with my upcoming FET, do I have to do an ERA test?
Yeah. So the answer is yes. An ERA test should be done, especially in this particular case. She's had 2 failed embryo transfers where you euploid embryos. So definitely doing an ERA would be a very good next step. And it should be done whether you're doing a natural cycle or doing a medicated cycle, because in either one of those cases, you certainly can have a displacement of the window of implantation. So if she had an ERA done before on a medicated cycle, that information doesn't really apply to a natural cycle. So she would need to have another ERA done on a natural cycle for the most part, and vice versa. If she had it done with the natural cycle and now she's doing a medicated cycle, then she would need to consider repeating the ERA on a medicated cycle, because the transfer and the ERA should really be done in the same type of endometrial preparation, which is what we talk about when we talk about a natural cycle versus a medicated cycle. So yes, she should do an ERA on a natural cycle.
Perfect.
Best of luck to that patient.
Perfect. And then how do you manage a natural cycle ERA? Like, what are the steps that you take, the monitoring that you do? So for
So
people who don't know, they'll know what's involved.
yeah, so we start monitoring on day 10 of the cycle, and they come every day for monitoring until we see when the ovulation is happening. So we want to see a rise in the elation, a rise in estrogen level, and then we want to see the rise in elation estrogen, then we want to see the drop in elation estrogen, so that we know approximately where the peak is.
Mm-hmm.
And then we also do an ultrasound to look at the lining and measure the lining is at least 0.7 and it's a triple layer. And then we count after that 6 days after the peak, after day 0. So the peak of the LH, and that's when we do the ERA. So for the transfer cycle, sometimes with the natural cycle, it's a little bit tricky to time it perfectly, because on one cycle, your LHP could happen at approximately 3 in the morning, and another cycle, it could happen at 2 in the afternoon. And that's gonna make things a little bit complicated, but certainly we try to mimic it as much as possible. And we do know that the window of implantation, usually when you get the ERA, you get about a 24-hour range. So we work with that.
Perfect.
Sometimes normally we do our transfers in the morning, and sometimes based on the ERA, we end up doing a transfer later in the afternoon. Yeah.
Good. Good. So here's another question that I got emailed today. I'm a new follower. Just want to say thank you for raising awareness. Thank you so much. I have a question for Dr. Garcia. We recently did our second round of IVF. We ended up with one normal embryo and one mosaic embryo. We plan to do a transfer using the normal embryo first, but curious to know what Dr. Garcia's opinion is for whether we should be using the mosaic embryo or not. What would you recommend?
Well, I think it would be hard to answer that question in isolation. Basically, when I have a patient in that situation, I look at, first of all, what degree of mosaicism. There is a low level mosaicism and high level mosaicism, like how many chromosomes are abnormal, what kind of abnormalities are present in the chromosome, what is the morphology of the embryo, and then look at the overall history. Generally speaking, if a patient has mosaic embryos and that patient is capable of doing IVF again and getting euploid embryos, I would prefer that because that's very time sensitive. So even if your mosaic embryo, you transfer it and then you get a miscarriage, now it's 3 months or 6 months, both emotionally and physically, to get back into the cycle, and the patient is already a little bit older, then that can have a significant impact on the overall chances of that patient getting to baby, which is what we really want, not just getting pregnant, but getting to a baby that you can take home. So sometimes if a patient has done many, many IVF cycles and a mosaic embryo is the only embryo that is left, and she's done both physically because of age or ovarian reserve or financially or emotionally, and the next step is going to be adoption or a donor egg, and it's just something about closing the chapter with your own eggs, then that would be something that I would definitely consider, transferring mosaic embryo. But generally speaking, I always tell patients, if you can make a euploid embryo, then that's better than a mosaic embryo.
Yeah, I agree.
So for that patient that you mentioned, the question would be like, what chances does she have of making more embryos? So I would want her to make more euploid embryos. Yeah.
Exactly. So I'm going to take two questions that we got right here on our live chat here. Is there a point of testing possible immunity issues anymore? What do you think, Dr. Garcia?
What does she mean by, is there a point in testing immunity issues anymore?
Yeah, I think what she's saying is with the advances of genetic technology, as far as testing embryos, is there any point in looking at immunity?
That's a great question, and I think there is. But I mean, this just made a good point that what we used to think was implantation failure. Now we know it's related to the chromosomes of the embryo. So now with the advances in genetic testing, there's a lot of situations where women are having recurrent miscarriages or having negative tests that can be attributed to the embryos not being normal. And you know that when you do IVF and you do PGS and you realize that this person wasn't making normal embryos in the first place. If you are transferring embryos that have been tested to be normal and you've done all the things that we've talked about, then I definitely believe that there is a point in checking immunity. Or if you have recurrent miscarriages as well, and not just one or two, but we're talking, I mean, I had a patient with 7 miscarriages. Then there are circumstances like that when it would definitely be worth looking at the immunity. But she's right, that is something that generally I recommend after you've done the IVF and the PGS, and we can see what the quality of your embryos is, and then we look at the immunity, not before.
Great. So I'm going to read a question that I got emailed to me today. So Dr. Garcia, I had my first chemical pregnancy in March with my first transfer. Those were both day 5 untested. So it sounds like she transferred more than one embryo. I have 7 more embryos left, 1 day 5 and 3 day 6 embryos, it looks like. And I'm not really sure what to think. Is it somewhat good that I had at least an implantation? That's the question.
Well, in a way, yes. I mean, we know that the endometrium is able to see an embryo and accept it and implant. So that's definitely great, especially when somebody that's come from a history of unexplained infertility, when you've never had a pregnancy. So a lot of times unexplained infertility, is it the sperm, is it the egg, is it implantation, is it the endometrium? And the fact that an implantation has happened can help a bit with that. So I do think it's a good thing, and she does have a lot of other embryos, even though they are untested. still a good number of embryos. I think it was 3 day 5 and 3 day 6 or something like that. So
Right.
depending on how old she is, you know, under 35 years of age, usually 50% of embryos are euploid. So, so she does have a really good chance of having a live birth with one of those embryo transfers, even though they weren't tested.
Okay, good. So I have two questions related to the ERA test in our live chat. And so one question is there an expiration date on the ERA test?
That's a great question. I don't think we really know the answer to that. I don't know what you think, Dr. Amy. I generally look at anything that has happened, like if you've done an ERA and then you've had a pregnancy, maybe that could change your window of implantation. Again, if you've done an ERA, if you've taken I don't know, 3 transfers and then the ERA was the one that led to the pregnancy, and then you've had a pregnancy and you've come back, you know what, you only have an embryo left and the ERA did it last time, let's just do it again, because I'm not sure that was the really important step. If somebody has had an ERA and I don't know, something has happened and they're coming for the transfer and they still has lots of embryos, then I don't know that I would repeat it. So I think I don't think we know the real answer to that question, but I basically look at a lot of other factors when I'm counseling my patients about whether it should be repeated or not.
Yeah, I'll double check my notes later, but I think it's within 3 years. It should still be reproducible, but you're right. I have the exact same approach. So for patients who, let's say something has happened, they've had a fibroid removed or a baby, especially if they have one embryo left, I do think it makes sense to repeat it for sure.
Exactly.
So the other ERA related question that we just got is this. So is there any other test other than ERA and PGS testing, and I know we talked about immune testing, to improve the chances of your embryos sticking?
Well, other than the immune testing, which we talked about in the show, which again, I would only recommend if there was a history of implantation failure. I don't think everybody needs to do immune testing prior to doing their first embryo transfer of their euploid embryos. But other than that, there is doing a sonal histogram to make sure the cavity is normal. There's no polyps, there's no fibroids, there's no scar tissue. And obviously an ultrasound, again, you want to make sure that there is no hydrosalpinx, like swollen fallopian tubes that can have an impact on implantation. Sometimes doing your hormones, like your thyroid levels, you want to make sure your thyroid levels are normal, you have normal levels of vitamin D. We want to make sure, not that it might necessarily affect implantation, but we always want to make sure there's no chlamydia and gonorrhea, so a simple urine test for that can help.
Yeah, good. So I have two questions related to autoimmune issues. So one question is, can autoimmune issues which cause miscarriages be treated?
Yes, it depends on what autoimmune issue specifically, but generally speaking, they can be treated. Yes, there is IVIG, there is steroids, there is Lovenox or a blood thinner, there's aspirin, there is the lymphocyte immunotransfusion, which I mentioned in the show that we did together. So there are multiple treatments. They don't always work, obviously, but there are treatments available, and most of the times it can be treated, yes.
Great. And then if you, let's say, didn't use prednisone for your ERA test, would that make a difference if now you're going to add prednisone for your frozen embryo transfer?
I don't think so. Do you think
No,
so?
I don't think so either. No, I agree. I agree. So I'm going to go now to a question that we had emailed to us. So Dr. Garcia, I had my my egg retrieval was last week. I'm curious about comparing day 5, day 6 versus day 7 embryos. I had 29 retrieved, 17 mature, 17 fertilized. Only 2 reached blastocyst stage on day 6. I'm still waiting to hear about my day 7 blast. My doctor said day 6 would be preferable to use over day 7. I'm worried those 2 won't pass genetic testing. Are day 7 not good? Are they less likely to result in a pregnancy?
So, yes, unfortunately, we do know that embryos that are day 6 have a little bit lower implantation rate versus day 5, and embryos that are day 7 definitely have a much lower implantation rate over day 5 embryos, even if they happen to be genetically tested. So an embryo that's chromosomally normal on day 7, those have a lower implantation rate than an embryo that's chromosomally normal on day 5. And I'm sure you would agree, Dr. Amy, with
I
that.
totally agree. I do agree.
But the thing is that, I mean, the thing about embryos is it's what you have, right? Like, you know, I did transfers of great embryos and I did transfers of not so great embryos. And at the end of the day, the pregnancy rate is either 0 or 100, right? You know, whether it's 30%, 40%, 45%, it's really the embryos you have, and you need to make a decision. Do I transfer them and hope for the best, or do I do another IVF cycle? But you've probably seen the worst embryos, the most unlikely scenarios turn into beautiful babies. So I never say, you know, you just never over.
Never say never.
So if they're your embryos, you give them all the love and you transfer them.
Exactly. Amen to that. So we have rapid fire, lots of questions just came through, but I'm going to ask Dr. John Norian's question. Hi, John. So he said, great info, just joined. What immune testing do you like to do? DQ alpha, HLA, or anticoagulopathin antibody, lupus anticoagulant, beta-2 glycoprotein? So that's his question for you.
Yeah, so we do the antiphospholipid antibodies that you mentioned. I don't do HLA, although I certainly am familiar with the research, and I think it's coming. It's going to become more common, but I don't do it. We do the natural killer cells. We do the cytokine levels, the Th1 to Th2 levels. And we test for the leukocyte antibody detention test, the LAD, in addition to the thrombophilia, so factor V latent, factor, the antithrombin 3.
Yeah, sounds good. So here we go with the rapid fire questions. What's the maximum age you use, or what's the maximum age requirement that you'll allow in your lab for using a woman using her own eggs, for someone who's ovulating regularly and had healthy embryos in the past?
So, you know, we talk about this all the time, and we don't, in our particular clinic, we don't just cross our arms and say absolutely not, unless, you know, I think women are smart and they have the ability to make decisions. I would tell a person, listen, your chances of pregnancy are less than 1% if you're over a certain age, 43, 45, 46. And, you know, usually after I have a really honest discussion with my patients, they say, thank you very much. I appreciate your honesty, and we're not going to do it because it is a lot of money. And you're basically telling me that it's extremely unlikely to work. I've done 44-year-olds in my lab. I know my other colleagues have done older than that in our lab. We don't recommend it, and it's, you know, across the country and all the countries, we all know that age has a huge impact on fertility and the chances are very low. But I believe in having a fair discussion with women and not having like a very strong, you know, I would never touch you if you're a certain age. I probably have never done anybody over 45 years of age, 44 years of age, I should say.
Got it. Cool. Okay, could cul-de-sac fluid affect chances of implantation? And would you recommend a Lupron FET protocol to prevent this fluid, as it is possibly from endometriosis?
Sorry, what affect the chances of implantation? Could what?
Cul-de-sac fluid.
Oh, cul-de-sac fluid.
Cul-de-sac fluid.
No, cul-de-sac fluid is very common, and it's usually related to a follicle that ovulates and ruptures, and it releases some fluid. Sometimes you can have it with endometriosis. So if you do have endometriosis diagnosed in other ways, yes, I would recommend a Lupron protocol. But having cul-de-sac fluid alone, without any other signs or symptoms of endometriosis, I don't think that automatically means that you need to do a Lupron protocol.
Yeah. Do you recommend 1 or 2 embryos to be implanted?
I generally recommend 1, especially if we know that we are doing genetic testing and the embryos are chromosomally normal. I actually feel very, very strongly about transferring only 1 embryo. Sometimes I have transferred 2, and that's where my twins come from. When we've had a situation, we've done 3 transfers, and I'm getting desperate, patients getting desperate, and I always say, you know, sometimes my objectivity is like, I want her to get pregnant so badly that, you know, I cave. But twins are a really, really high risk. And, you know, one third of all twins deliver prematurely. And having 2 babies in an incubator is nothing that I wish on patients that have struggled so hard to become pregnant.
Right.
So the goal is not just 2 lines on the stick. The goal is a healthy pregnancy and a healthy baby that you can enjoy.
Right. Okay, so here is another question. I have healthy menstrual cycles that come on time each month. Does that mean I should have no issue conceiving?
I have what? Regular?
I have regular cycles. Does that mean I should have no issues
No.
conceiving?
That's great that you have regular cycles, but I mean, it takes more than regular cycles to conceive. There is the quality of the eggs, there's the sperm, there's the tubes, there's the uterus. So if you've been trying for over 6 months if you're over 35, or over 12 months if you're under 35, you should definitely see a fertility specialist.
Yes.
Even with regular cycles.
Or get your tushy checked, right? So get your tubes, your uterus, your sperm, hormones, your genetics.
Yeah. Yep. Get your tushy checked. That's
Check
right.
your tushy check. Okay, here's another question. How would you rate day 5 or day 6 3 BBs? Are they considered good, and what is the implantation rate for them?
So 3BB is sort of average, like the top embryos are 5 and 6, 4, 5, and 6, and the bottom embryos are 1 and 2. So 3 is right in the middle. Because it's average, it's probably the most common embryo. You probably would agree, Dr. Amy. It's sort of the, you know, so I've seen lots and lots and lots and lots of babies from 3BBs. So I would consider that an average embryo, and if they are chromosomally normal, and they are day 5, then the implantation rate is still pretty good, like 65, 70%.
I agree. Here's another question. What's the difference between a good and a bad embryo?
That's a great question, actually. I guess it depends what you mean by good or bad. So what fertility specialist likes to see in an embryo, I don't want to call it good or bad, but what we like to see is that they were made on day 5 versus day 6. We like to see that they're fully expanded. That means they are 3, 4, or 5. We like to see that the inner cell mass is really nice, and they're graded an A when it's really nice and a C when it's not very nice. The inner cell mass is the part of the blastocyst that is going to become a baby eventually. We like to see that the cells around it, which are going to be the trophoblasts, those cells are going to become placenta eventually. So we want them to be also very nice looking and compacted and uniform. And if that's the case, they're graded A. And if that's not the case, they're graded B or C. And we like to see ideally that it's chromosomally normal. So an embryo that is graded like 5AB on day 5, chromosomally normal is like top notch. It's a really, really good embryo. And an embryo that is like a C, Cs, we don't like to see Cs, whether in the inner cell mass or in the trophoblast. And then if a C and it's a day 6 as well, like a 3BCO on day 6, is what we consider a suboptimal embryo. But again, I've seen tons of babies from embryos like that, and I'm sure you have too, Dr. Amy.
Right.
So.
Here's another question. Is it possible to do an IVF cycle with the diagnosis of endometrial cancer grade 1?
Is it possible to do an IVF cycle with a diagnosis of endometrial cancer grade 1?
Correct.
That's a great question. I guess you would have to look at many different aspects. So we wouldn't do a transfer for sure. We would be doing like an egg retrieval only, and removing the eggs and freezing the eggs, or removing the eggs and doing the genetic testing and the freezing of the embryos. And then you would want to have that treated and then do the transfer. So if it's something that can be done on a very timely manner, like I wouldn't want anybody to think I got my diagnosis of endometrial cancer and I'm gonna not do anything about it because I want to do an IVF in 6 months. That would be completely wrong. But if you're working closely with an oncologist and a fertility specialist, the care could be coordinated and it can be done. Yes.
Okay, here we go. How to get IVIG approved by insurance for implantation issues. I don't know what kind of coverage your patients have there
We
for
don't
IVIG.
Yeah, we don't get it approved by insurance because it's not the standard of care. So I have never been able to have it. Actually, no, that's not true. Some patients do, but I have nothing to do with it. So I tell them, you're not going to get it approved. I'm telling you. And they come back and they're like, you were wrong. It's got approved. And I want to cry with happiness.
Right,
But it's not
right.
because of anything I did. It's just the insurance company happened to like let it slide. But there's
Got it.
nothing really, when they come down to me and it's like, can you write a letter? That has never been successful.
Got it. Okay. How do you treat high NK cells? I know it's controversial, but I don't believe my doctor believes in this theory, but I'm worried about any possibility.
It's definitely controversial, and it's not your doctor's fault. It is not the standard of care, and that's something that I talk to all my patients about. It's not. The way to treat it, sometimes it could be treated with steroids, and sometimes it can be treated with IVIG or with intraleaflet infusions. But it's definitely very controversial, and for a reason. Like when you look at the research, the studies going in all kinds of directions. So certainly it's very difficult for all fertility specialists to look at the data and agree, because it's kind of all over the place. But those are the main treatments: is steroids or IVIG or intraleaflets.
Yeah. This is a great question. Who has the last say on the decision about how many embryos to transfer?
Well, in Canada, if we're doing a funded cycle covered by the Ontario government, then there is no option to have more than one embryo. The Ontario government says, I'm paying for IVF for you, so these are the rules. You need to have an only embryo. I've never, I guess the last say, so outside of the funded program, I guess the last say goes with the patient. But in my experience, I never had to do that. I never had to be in a situation where I am 100% dead against it, and the patient is like, well, I just want my 2 embryos and I'm not listening to you. It's always a conversation. So I've never been in a situation where it's really come, I've done 2 embryos, but because I'm like, yeah, I'm with you. You've done this many cycles. And, I think that we need to do 2 embryos now. So it's never been a situation where we're butting heads, so to speak. But I don't know. That's a good question. I've never been in a situation when I think it's absolutely dead wrong to have 2 embryos put in and my patient disagrees.
Right. Okay. Okay. Here's another one. Is it common for endometriosis to heal itself after a healthy pregnancy and delivery?
Yeah, it is, because basically when you're pregnant, it's almost a little bit like Lupron in a way that you're not ovulating anymore, so your hormone levels are super high, but they're steady, as opposed to when you're not pregnant, where you get estrogen, progesterone, and that's what tends to fix endometriosis. So many times after pregnancy, women, cure is a strong word, but women have decreased amount of inflammation, decreased pain. Sometimes they can have better pregnancy rates after pregnancy. And certainly I've had many patients when I know they had endometriosis, I've done the laparoscopy, I know how bad it was. Then I go and do their C-section and I'm like, those cases, right? Everything is a lot less inflamed, so to speak. Right. And sometimes the benefit of the less pain can last a little bit postpartum. Sometimes it does come back.
Yeah. I just love that you do C-sections on your patients. I wish that I could do the same.
I'm doing one tomorrow.
That's awesome. That's incredible. So when do you usually check a HCG level post of a frozen embryo transfer? How many days after your transfer do you check?
Between 10 and 12 days, depending. Okay. I don't test on the weekend, so we kind of put it between 10 and 12 days. Yeah.
Great. So I have a question here. What are good initial HCG numbers you expect day 12 post frozen embryo transfer?
Oh no, I want to answer that question.
I know.
Well, generally we want it to be usually day 12. I would say about 200 in that range, but quite frankly, I've seen it all. I mean, I've seen levels that are really low, and the patient is basically, I don't want to come back. It's over. I want to stop my medication, and I'll be like, please, just listen to me. Come back. Let's do this again. And the level like quadruples by the next day, and they have babies. So I've seen it all. It's not over until you see that level drop. And I'm sure you can have a million stories like that. We could probably talk about it.
One day we should. I call it HCG hell is what I call that
Oh,
when your
yeah.
level's low. And I just say, we just got to ride this out and see what's going to
That's
happen.
right.
Yeah.
That's right. It's so variable. ACG is so incredible variable.
Yeah.
And everybody's a little bit different.
Yeah. Here's another one. Are there some people that do better with a fresh embryo transfer versus frozen?
That's a great question. Wow, these questions are great.
I
So this
know.
is what I think about yes. So the answer to that is yes. And the way that I look at it is I love analogies. And one of the analogies that I use is, you know, so exercise is great, right? Every doctor would tell you you should exercise. So if you take 100 people at random and you make them do, I don't know, planks or jumping jacks or whatever, you're going to see their heart rate goes up. They're going to feel great. So that's good for them. Out of those 100 people, somebody would probably drop dead, because if you take 100 people at random and somebody there has horrible heart disease or horrible lungs or whatever, and you make them do jumping jacks and go up the stairs and run a mile, they're not going to tolerate it and they're going to be sick because of their exercise. So yes, exercise is good for you, but that's why they tell you should always check with your doctor before you start. So embryos come from eggs and sperm, and sometimes eggs just don't have all the strength and all the pieces that you need to undergo retrieval, fertilization, culture, freezing, thawing, biopsy, and all of this stuff. And sometimes, even though they're normal, when they go through all of that, they use that energy in that process, and then there's not enough energy for doing the transfer. So generally speaking, whenever I see patients that are really struggling to make a single blastocyst, or they have done PGS and euploids, and the embryos are, they don't look so great, and we do a transfer and it's euploid and it doesn't take, and we've done it again. Sometimes we do have to go back to basics and say, listen, I'm going to do as little as possible. Sometimes I've done a natural or modified natural cycle. Don't even do the ICSI if you can afford it. By the sperm. If the sperm is okay,
Right.
do a day 3, a day 5 fresh, and just let the embryos alone or let the eggs alone, because sometimes they just can't tolerate all that activity.
Right. So the same person asked this question: Why can I get pregnant on my own and not with frozen embryos? I've gotten pregnant once with IVF, but it was with a fresh, but never with a frozen.
No. Well, I don't know what the answer to that would be, but I mean, it would be looking at how old were you when you had your fresh, what changed, did you get a fibroid, did you get a polyp, what were the embryos like? There's a lot of reasons why that could be the case.
Yeah, I agree.
Yeah.
So a couple questions here. Will the session be available on YouTube? And the answer is yes. And then there are a couple questions on the ERA test that we already answered at the beginning of the show, so I'm not going to ask you those again. Here's a good one. Does ICSI increase fertilization rate even if there's no sperm issues? What do you think?
Well, that's a controversial one too, and I believe that ICSI it's overused, and I try not to overuse it. So whenever if I have a couple that has unexplained infertility, which means normal sperm but no pregnancies, I tend to do half IVF and half ICSI, because doing all ICSI doesn't really give me an opportunity to understand if there is an egg and sperm interaction issue. If I have a patient that has normal sperm and proven fertilization, they have pregnancies, they have miscarriage, they have children, and we're doing this for another reason, then I tend to just do all IVF. Because ICSI, it's manipulating the egg. You gotta take it, you gotta remove the layer around it, you gotta take the sperm and put it inside. And IVF is more natural from the point of view that the best sperm, I wouldn't say the best sperm, but all the sperm has to eat away at the layer of the egg until one fertilizes. It's not for everybody, because you need to have really good sperm for this to happen. And again, I would never recommend doing all IVF in somebody who has no proof of fertilization, because what happens then is you go, well, now I know why you're not getting pregnant, except that you've gone through all of this and you don't have any embryos.
Right.
But does it increase fertilization? I suppose that, I mean, it's hard to say. It depends on whether you have proof of fertilization before or not. I think that if you know for sure, for the most part, that the sperm is capable of fertilizing without ICSI, I don't know that ICSI is necessary.
Got it.
But you don't really know that unless you've done it before, which is the tricky part.
Right. And how are you doing on time? We have a whole bunch of questions, but I want to be sensitive to your time. Are you doing okay still?
I have about 10 minutes left.
Okay, here we go. How is adenomyosis addressed? And I'll just ask you more specifically, how do you treat it before transfer?
Well, that's a tricky one. Sometimes I treat it with Lupron. Sometimes, sometimes it's there and we talk about it and we do a transfer and there's a pregnancy. You have to look at so many other factors than the adenomyosis alone, but generally we treat it with Lupron. But there's not a lot of studies on it. I don't know what you do, Dr. Amy, but it's controversial. There aren't a lot of studies on it, but I do try to treat it with Lupron when I can.
Yeah, I do a test. It's called the BCL6 test. Obviously, if someone has very obvious adenomyosis and it's very severe, then I talk about Depo-Lupron, just like you're saying. But if it looks like it's mild to moderate, then I decide the medical management based on that score, the BCL6 score, and then I guide the treatment that way before transfer. So, okay, here we go. Have you started doing frozen transfers?
At Markham Fertility, yes, we started this week. Yep.
Cool. That's awesome. What is the purpose of administering HCG after a positive pregnancy test? Do you do that?
Oh, that's a great question. So there was a couple of studies a while ago that looked at that and that looked at the possibility. So HCG is a little bit like LH, and we do know that in a natural pregnancy, the ovary has something called the corpus luteum. The corpus luteum releases the egg, and then the egg fertilizes an implant, and that corpus luteum continues to make LH to support that pregnancy, or continues to make actually HCG, I should say, to support that pregnancy. So there's been a theory that using HCG would support that corpus luteum to allow the pregnancy to continue and decrease the miscarriage rate. If you're having a medicated frozen embryo transfer, there's no corpus luteum. So that is a situation where the HCG wouldn't be there. If it's a natural frozen embryo transfer, then technically there was a corpus luteum, and technically that corpus luteum is working, but we're giving you tons of progesterone as well. So to make the long story short, we have been using it a little bit more, what's the word I want to use? Because we have seen really good results with that, but looking at the evidence, I'm not sure that we really need it at this point. So sometimes people can get really nauseous with it, or they can have a lot of irritation, and I usually tell them to stop it and not to worry about it if they're not tolerating it well.
Great. So there's another kind of ERA related question. Should you wait between your ERA cycle and your transfer cycle? Should you put a month between?
No, I don't think that you need to put a month between. I think it's actually better to go right after. I agree.
I agree. And there's no reason to rush into it either. If you want a break, you can definitely take a break.
Exactly.
So everyone, I close the questions since you guys are asking so many. We're going to have Dr. Garcia on again, but I close the questions for tonight because I just want to get through all the great questions you guys have asked so far. So wondering why a fertility specialist would recommend IVF without trying an IUI cycle first.
Oh, okay. So there could be a lot of reasons for that. Some of the reasons would be age. So if you're a little older, we know that IUI has a much lower pregnancy rate. So doing IUI, if you get pregnant, great. If you don't get pregnant, now you've wasted some time. Like, time has passed. I hate to use the word waste, but time has passed, and now you're doing IVF when you're older, which would technically decrease your pregnancy rate. It could be related to some issue with your fallopian tubes. So if your fallopian tubes are affected, then really IUI is very unlikely to work, because that's when the egg and the sperm meet. It could be related to sperm as well. So if the sperm is not perfect, like for IUI, sperm has to be almost perfect or almost perfect, because you're basically throwing a sperm in there and you're letting them do all the work. You're not doing the ICSI, you're not doing the fertilization in the test tube. And then outside of that, IVF just gives you a better pregnancy rate than IUI, and it also gives you the opportunity of creating embryos that you can use in the future. So you have to think, how many kids do I have? How old am I today? And how old I'm going to be when I want to have my second child? So if you're 37 when you're coming to the fertility specialist, even if you're really lucky to conceive with your first IUI, that might put you at 39 when you want to have your second child. And that could become very difficult to conceive if you don't have frozen embryos.
Right.
So those are just some of the reasons.
Perfect. How does endometriosis affect implantation if the scar tissue is outside the uterus?
That's a great question. So there's two main theories for that. One is just overall inflammation in the pelvis, and this is where the Lupron can help. And the other theory is sometimes with endometriosis, you can have swollen fallopian tubes, and the swollen fallopian tubes can have fluid, and that fluid in the fallopian tubes can go back into the uterus, and it's kind of like drown the embryo. But in other words, there is fluid in there, and then the embryo is in there trying to implant. And studies have shown that it can have a decrease in implantation rate from that mechanism as well.
Yeah. Here's another question. I've had 2 miscarriages and now 3 failed IUIs. Are my chances of a successful IVF decreased because of this?
No, I think your chances of a successful IVF would not be decreased because of that history. Particularly, it would be looking at everything else, like your age and your ovarian reserve and the sperm and all the other factors.
Yeah, good. Okay. When someone has had a failed cycle, what do you think must be changed during the next cycle?
Well, I guess you need to see the show.
Yeah. No, for sure. I mean, our show, Dr. Garcia gave us a step-by-step outline, and then I also wrote the show as a blog article, and it's all outlined there, and I can forward it to Cherished Olivia as well. So here's another good question. What is the most important question to ask my infertility specialist before I begin IVF?
I don't think that is one important question. I think you need to ask all the questions, like, you know, how is IVF going to help my particular situation? Like to me, when I have a conversation about IVF, it's about explaining what IVF is, but it's also about explaining IVF for the particular patient, because IVF is very different for different patients, and it's about the expectation. So I always talk about what is my expectation as a fertility specialist of what your cycle is going to look like based on what I know about you. And that is the sperm, the ovarian reserve, the weight of the patient, the position of the ovaries, the sperm quality, issues like adenomyosis, endometriosis, and things like that. So I think it's important to, when you talk to the specialist, is to have a very clear understanding of what your issues are for fertility. And sometimes it's like there is no issues and it's just an explaining fertility, but you need to understand that, like why is it called an explaining fertility in your situation, and what the expectations for IVF are on the basis of all of your factors.
Right. Okay, I'm going to just take 3 more questions and then we'll let you go about your evening. Thank you again for your time and expertise, Dr. Garcia. So how is it possible that a completely healthy person can have a failed IVF cycle and not a single test can determine anything was wrong beforehand?
So when you say a failed IVF cycle, is this one transfer or?
Let's just say possibly no blasts or no blasts, but none were normal.
Yeah, okay. So that is super frustrating, right? So that's me. That was me, I should say. I was 33. I don't want to make this about me, but I was 33 when I started, super healthy, you know, work out all the time, eating perfect, you know, super type A. Oh, I could do this. I'll get pregnant, no problem, because everything that I want, you work hard for it and you just get. And 5 cycles later, I was still pulling my hair out thinking, what is wrong? And it happens. So sometimes egg quality, this is one of the things I talk to my patients about. Egg quality is one of those things that there's no test for that. There's absolutely not a single test that Dr. Amy or myself or anybody could do on a patient that is going to tell us what your eggs are going to do when you do an IVF cycle. And sometimes one IVF cycle doesn't even tell you that about egg quality. So you can have one cycle with terrible egg quality and then another cycle with amazing egg quality. Mm-hmm. So there is something about egg quality. There's a lot about egg quality that we don't understand. But one of the things that we find when we see people with unexplained infertility, which I assume is your question because you're saying you're perfectly healthy, is that the egg quality is poor, even though the patient is healthy and every test has been normal. And that's unfortunately something that you can't really determine until you do IVF. So I always tell my patients that I'm doing IVF to get you pregnant, but IVF is also like coming into a room and turning the light on and seeing a little bit of a mess. So
Mm-hmm.
you kind of uncover things with IVF that you had no way of knowing prior to doing it. So sometimes you need to be prepared for finding things that you really weren't keen about knowing, but at least it's information that you can use to move forward.
Right. Okay, so last two questions. What are the pros of IVIG before transfer, and what are the side effects?
So some of the pros is that it decreases the Th1, Th2 levels, so the cytokine levels, and that has been thought to be associated with improved implantation. Side effects, it is a blood product, so just like a blood transfusion, you can have a transfusion reaction, you can have a fever, you can have a rash. Very rarely you can have a severe anaphylactic reaction that could be life-threatening. But those are the main side effects. It is a blood product, so it's all of those reactions.
Okay.
Yeah.
Last question for the night. Thank you again for all the information. Here we go. I'm day 7 receptive on a medicated cycle. Would Lupron change that if it wasn't part of my ERA protocol?
So technically, what really changes, it's all about the progesterone. So if you use the same progesterone that you did in your ERA protocol, and this is what I mean by medicated. So in a medicated cycle, you wouldn't have made your own progesterone. Whether you use Lupron or not, the key is that you didn't make any. And they gave you some, and they did the ERA based on the progesterone that was given to you. So if we now do a Lupron, and you're also not making your own progesterone because of the Lupron, and they're giving you the same progesterone at the same time and the same amount, then your ERA should be comparable.
Yeah, that's what I think too. But I know some people disagree with me, but I'm glad you agree. That's why you're on here today. I'm just kidding. Of course,
We
I'm
didn't even
kidding.
talk about this before.
Yeah, good. Well, thank you for your time tonight. We have to have you on again because I had to close the questions down because we got so many. And of course, we'd love to have you back. Will you come
Well,
back again?
you are a fertility specialist too, so your patients are very lucky that you can answer all of these questions
Yeah.
without me.
Yes. Well, good. Well, thank you again for being on. Thank you
You're
everyone for
welcome.
watching
I hope
today.
that this was helpful, and I wish you
Absolutely.
all the best. And remember not to lose hope, and to keep asking questions and keep trying, and trust your doctor. I don't have all the answers. I don't want anybody to think I do. Sometimes fertility specialists do things a little bit different because they have experience that they believe, and it's a little bit of an art. So trust your doctor, even if it doesn't sound exactly like what I'm saying. There is a lot that we don't know, and there is a lot of opportunities for people to have their own little special recipes and help you succeed.
Yeah, that's great. Well, thank you for closing with that.
Okay.
Okay, guys, well, have a good night. Bye, Mavis. See you
Okay.
later.
Bye.
Bye-bye.
Take care.
You too.